Last year, I made a video playlist of all of the ICD-10-CM coding guidelines. Now, October 1st of every year, there are new additions to ICD-10-CM, including lots of new codes, and this year we saw guideline updates as well. Now, it wouldn't make sense for me to go back and re-record 100 hours of video in order to replay some of the same information when there's just been some changes. So that entire playlist from last year still stands. It's just that now there's some additional information that we're going to be adding into it. So today we're going to go over the 2022 changes for ICD-10-CM guidelines. Hey everyone, I'm Victoria. I'm a medical coder, auditor, educator, and content creator, and on my channel I provide tips, tricks, and tutorials to help you be successful in a medical coding career. If you haven't already, I would highly encourage you to subscribe and hit that notification bell so that you can get alerts when I post new episodes. So as I mentioned earlier, ICD-10-CM codes update October 1st of every single year. CPT and HCPCS codes update January 1st of every single year. One important thing to note is if you're sitting for any AAPC certification exams, they go based off of calendar year. So the code changes that take place on October 1st will not be implemented into the exam until January 1st. That is when they change the exam. So between that October to January 1st timeframe, none of those new codes will be in the exam, and actually you are not allowed to use the next calendar year exams for your test during that time frame. You have to use the calendar year's books for the exam. Now it is a little bit discouraged because of the code updates, but you can use a prior year's code set book for your AAPC exams. HEMA is different, but you can't use a future calendar year's code books for sitting for your certification exams through AAPC. For example, if you're sitting for your exam in November of 2021, you cannot use your 2022 ICD-10-CM book, even if you have that already, because they're going to already be out by then. And actually, none of those updated 2022 codes will be in that exam yet because they don't update it until January 1. Now for this video, I'm just going to go over the guideline updates. I will be making a full webinar available at some point to cover the entirety of the ICD-10-CM updates as well. For the purposes of this demonstration, I'm not going to go over things that are really minor changes. Maybe if it was just a slight word or something that really doesn't have much impact on the code selections or the guidelines as they stood. So in 1B2, our general coding guidelines, there was an important clarification on the level of specificity and how that level of specificity has to be documented in the medical record. So we're supposed to code to the highest extent that we can, but that extent needs to be in the medical record. We can't just pick a higher level of specificity in the EMR when that documentation does not support it, or code to a level of specificity that is not in the documentation just because we don't want to use an unspecified code. Now, another clarification here is there is some notes about these changes that are taking place in the U codes. And if you remember, those U codes are chapter 22. They don't come alphabetically, they come after chapter 21. So it's Z codes, and then after that is chapter 22, which is your U codes. And those are your codes for special purposes. We saw those for our vaping disorders, as well as some of our COVID-19 codes. So in here, it's including that those are used for diagnoses, symptoms, conditions, problems, or complaints, or other reasons for the visit or encounter. So we did see some changes to those U codes specific for COVID-19, and we will go over those as they come up in the chapter-specific guidelines. 1B13 talks about laterality, and all of this information that's in bold, if you look at the bold text, those are specifically what has changed, the bold text. You can go and download the ICD-10-CM 2022 information. I'll link it below, and then any of those guidelines that are bolded, that's the new information. So it says here, when laterality is not documented by the patient's provider, code assignment for the affected side may be based off of medical record documentation for other clinicians. So for example, a patient might come in with a wound and the provider just said, oh, it's on their leg, but we may have documentation from a wound care nurse that day that said, oh, it was the right leg. And in that case, we can use that documentation from the wound care nurse to use that specificity that it's the right leg. However, If the provider says left leg, the wound care nurse says right leg, then we need to go back and query that provider because there's a mismatch in that documentation. We have to clarify, was it the right, was it the left? Did they have both, but maybe they only treated one that day? It also notes that codes for unspecified side should be rarely used. So basically only when the documentation doesn't support it and we are not able to query that provider and say, hey, you did carpal tunnel surgery on this patient. Was it the right side of the patient or was it the left side of the patient? They should really be documenting right or left and not leaving that just stating carpal tunnel. In 1B14, the documentation by clinicians other than the patient's provider. Now, we saw this change a little bit last year as well, where it talked about how other providers can document certain components of the diagnoses, like a BMI or like a ulcer level. And now it clarifies the BMI, the depth of the non-stage pressure ulcer stage, coma scale, the stroke scale, social determinants of health, which we'll play in a little bit more as well. Laterality, and now blood alcohol level is a new one as well. But those can be documented by someone other than the patient's provider. So it says in this context, clinicians other than the patient's provider refer to healthcare professionals permitted based off of their regulatory accreditation requirements or internal hospital policies to document a patient's official medical record. So we're kind of talking here maybe about scope of practice, and then in absence of there being a scope of practice, if there's an internal hospital policy. Like let's say it doesn't specifically say that a medical assistant can document the patient's pressure ulcer stage. Now, maybe in that particular hospital, you write a policy, you have that written down that says, yes, we will allow medical assistants to document the pressure ulcer stage. And then at the bottom, it says about how the BMI, the coma scale, the stroke scale, blood alcohol levels, and social determinants of health, which we'll talk about more, should only be reported as secondary diagnosis. So there should be a different primary or first listed diagnosis. Now, this new section, it discusses reviewing all of the components of the medical record as the combination of all documentation by the healthcare providers is what ultimately drives the code selection. So it's not just blindly picking something in the EMR. That has to be supported by the documentation. It's complete documentation in the medical record. It says cannot be overemphasized, and without such documentation, accurate coding cannot be achieved. So really stressing about how it is truly the level of specificity in the documentation that has to drive that diagnosis code selection, and the entire record should be reviewed to determine the specific reason for the encounter and the conditions treated. This one was just a small one, but I did want to include that in the use of Z codes. It says that they are used to assign further explanation for the reasons for the presenting for healthcare services, including transfers between healthcare facilities, or to provide additional information that's relevant to the patient encounter. Now, this guideline, this is for Chapter 1, which is our infectious disease codes, and this is new. So 1C1I, history of HIV managed by medication. If a patient with documented history of HIV disease is currently managed on an antiretroviral medications, we assign code B20, which is our HIV code, and then we assign code Z79.899, other long-term current drug therapy, and that would be assigned as an additional code to identify the long-term antiretroviral medication. That is a brand new guideline for 2022. Will take effect October 1st of 2022. Next, we have some clarifications here on our codes for signs and symptoms of COVID-19. So this is on two different slides. So the reason there's no bold on here is because I want to kind of show you the entirety of this guideline, but I didn't want to pack it down so small that it was hard to read. So for patients that are presenting with any signs or symptoms associated with COVID-19, such as fever, but a definitive diagnosis hasn't been established, we use those signs and symptoms, such as the cough or the shortness of breath and the fever. If they've been in contact with someone who is COVID positive or someone who is suspected to be COVID positive, we assign Z20.822, contact with or suspected exposure to COVID-19, and then this is where it's changed. So for individuals who have previously had COVID-19 without residual symptoms, so they are not having any sequela, they're not continuing to have shortness of breath, they're not continuing to have respiratory issues or fatigue, and they're being just seen for a follow-up evaluation, and COVID tests are negative, we assign code Z09 and counter for follow-up examination. If they do have follow-up visits for individuals with symptoms or conditions that are still related to a previous COVID-19 infection, it tells you to look at code guideline 1C1G1M, and we're actually going to follow up and look at that guideline in just a moment. Now, this one here is where you will see the first indication of this new code that we have, and that new code is U09.9, and that is a post-COVID-19 condition unspecified. Now, this is the guideline that we talked about where it says here to see this one for individuals for visits that are follow-up visits that have symptoms after their COVID-19 infection. It says to see this guideline. That's this one. So it says for sequela of COVID-19 or associated symptoms or conditions that develop following a previous COVID-19 infection, we assign the code for the specific symptoms or conditions related to the previous COVID-19 infection, if known, and code U09.9, which is that post-COVID-19 condition unspecified. Now, it says code U09.9 should not be assigned for manifestations of an active COVID-19 infection. So this is for patients who have recovered from COVID-19. If a patient has a condition associated with a previous COVID-19 infection and develops a new COVID-19 infection, so now they're reinfected with COVID-19, code U09.9 may be assigned in conjunction with code U07.1, COVID-19, to identify that the patient also has a condition associated with a previous COVID-19 infection. Codes for the specific conditions associated with the previous COVID-19 infection and codes for manifestation of the new and active COVID-19 infection should also be assigned. So if they're having a current COVID-19 diagnosis and they still have manifestations from their previous one, we can assign both those codes. Another brand new guideline for 2022, 1C2S, breast implant associated anaplastic large cell lymphoma. So breast implant associated anaplastic large cell lymphoma is a type of lymphoma that can develop around breast implants. And in those cases, we assign code C84.7A, anaplastic large cell lymphoma, ALK negative breast for BIAALCL. And don't assign a complication code from chapter 19. Couple of changes to our diabetes code. So in this particular section, 1C4A3, there's a little minor changes. So it says here additional codes should be assigned from category Z79 to identify the long-term or current use of insulin, oral hypoglycemic drugs, and now there's a new section here, or injectable non-insulin anti-diabetics as follows. If the patient is treated with both oral and insulin, we use Z79.4, long-term current use of insulin, and we use Z79.84, long-term current use of oral hypoglycemic drugs. Now this one, again, a brand new guideline, 1C5B4, medical conditions due to psychoactive substance use, abuse, and dependence. So this guideline states that medical conditions due to substance use, abuse, and dependence are not classified as substance-induced disorders. Assign the diagnosis code for the medical condition as directed by the alphabetical index. So we look under the alphabetical index, and along with the appropriate psychoactive substance use, abuse, or dependence code. So for example, the alcoholic pancreatitis due to alcohol dependence, we assign the appropriate code from subcategory K85.2, alcohol-induced acute pancreatitis, and the appropriate code from subcategory F10.2, such as F10.2.0, alcohol dependence uncomplicated. It would not be appropriate to assign just the code F10.288, alcohol dependence with other alcohol-induced disorder. So we go to our alphabetic index, we look up the alcoholic pancreatitis. It's going to give us the alcohol-induced acute pancreatitis, And then it's probably in the guidelines, if we were to look up K85.2, tell us to use an additional code, and it would probably guide us to those F10.2 series codes, the ones that they want us to use in addition. Another new one related to blood alcohol levels. So a code from category Y90, which is evidence of alcohol involvement determined by blood alcohol level, that can be assigned when this information is documented and the patient's provider has documented a condition classifiable to category F10, which is our alcohol-related disorders. The blood alcohol level does not need to be documented by the patient's provider in order for it to be coded. So if you remember previously, we had looked at those guidelines where it said someone other than the patient's provider, another clinician, another person involved in the patient's care, such as like an LPN, they can document that blood alcohol level. We used to just be like things like BMI and ulcers. Blood alcohol level is included in that, and now we're seeing that noted again here in this brand new guideline regarding the blood alcohol levels. A little change to section 1C12A2, unstageable pressure ulcers. So if you look here at the very end, it says, if during an encounter the stage of an unstageable pressure ulcer is revealed after debridement, we assign only the code for the stage revealed following debridement. So sometimes when a provider is doing a debridement on an ulcer, because there's so much dead tissue and slough and stuff that they have to scrape off, they can't tell at that point what the stage of the ulcer might be because it's kind of obscured. But then they do a debridement and then they go, oh, you know what, this is really a stage 4 pressure ulcer. We code at that point for the stage 4 pressure ulcer because that was the stage that was revealed after the debridement. But again, that has to be driven by the documentation. A little note here for our OB coders. So when delivery occurs during the current admission and there is an in-childbirth code option for obstetric complication being coded, the in-childbirth code should be assigned. When the classification does not provide an obstetric code with in-childbirth option, it's appropriate to assign a code describing the current trimester. In our 1C18E section for coma, it says code R40.20 unspecified coma may be assigned in conjunction with any codes for any medical condition. However, you should not be using the codes for unspecified coma or the Glasgow Coma Scale for a patient who's actually in a medically induced or sedated state. Another change to the coma scale section, you'll see here that it gives a different range right here for the coma scale codes. And then there is this section at the very bottom where it says if multiple coma scores are captured within the first 24 hours after a hospital admission, we assign only the code for the score at the time of admission. ICD-10-CM does not classify coma scores that are reported after admission but less than 24 hours later. In 1C21C4, we see a section added to the history of. So it states that the reason for the encounter, for example, screening or counseling, so we're screening for colon cancer, for example, should be sequenced first, and the appropriate personal and family history codes should be assigned additional diagnoses. So colon cancer screening, if the patient's coming in for a screening, we would use our screening code first. Second, we would use if they have a family or personal history of colon cancer. So screening code first, then that personal or family history comes after that. Change in regards to our codes for Chapter 21 in regards to counseling. So it says persons encountering health services for other counseling and medical services not elsewhere classified is Z71. However, note Z71.84 encounter for health counseling related to travel is to be used for health risk and safety counseling for travel purposes. And then we see code Z71.85 encounter for immunization safety counseling is to be used for counseling of the patient or caregiver regarding the safety of the vaccine. This code should not be used for provision of general information regarding risks and potential side effects during routine encounters for the administration of vaccines. So what does that mean? Well, let's say it's flu shot season. The patient comes in for their visit. The doctor says, hey, while you're here, you should probably get your flu shot. And the patient says, yeah, okay, I should get my flu shot. They do the normal counseling that they would. Hey, look out if you have a fever or a rash or a sore arm, etc. And this is what you can take if you start getting sore. That would be the routine vaccine counseling. But if a patient says, I've been thinking about taking the Gardasil vaccine, I'm just not sure, I really want to talk to my provider about this to make sure that I'm making the right choice about receiving this vaccine, that's when we use this code, that Z71.85, where we're having counseling regarding that vaccine, where we're talking about that patient-provider conversation that they're having about specifically that vaccine. That patient has questions. They maybe saw some things on the internet. They're a little bit hesitant, and we're having that counseling session, not just because they're coming in for the vaccine and we're doing the routine kind of, here's your risks of, if you're allergic to eggs, you shouldn't be taking this shot, et cetera, et cetera. Now, social determinants of health. How much have I been stressing this? If you haven't watched my video already, I do have a whole video that you can check out specifically on social determinants of health, because they are playing a bigger part in coding and in healthcare. So 1C21C17, new Chapter 21 guidelines, social determinants of health. And it states that codes describing social determinants of health should be assigned when the information is documented. So for social determinants of health, which are found in categories Z55 through Z65, they're things like the patient is homeless, they're in a foster care system, they're having conflicts with their spouse. For social determinants of health, such as those found in that category, persons with potential health hazards related to socioeconomic and psychosocial circumstances, code assignment may be based on medical record documentation from clinicians involved in that patient's care, but they're not that patient's provider, because that information represents social information. It is not a definitive medical diagnosis. The fact that a patient is having trouble affording their medication, that's not someone making a diagnosis of that. That is a social factor. So that can be documented and coded and abstracted and used when it's documented by someone who's not that patient's official provider. So for example, coding professionals may utilize documentation of social determinants of health from social workers, community health workers, case managers, or nurses if that documentation has been placed into the medical record. Patient self-reported documentation may be used to assign codes for social determinants of health, as long as that patient self-reported information is signed off and incorporated in the medical record by a clinician or a provider. So say, for example, the patient says, hey, I'm in an abusive relationship with my boyfriend, and that's documented somewhere maybe on an intake form. The provider pulls that into the record, signs off on it. We can use that information. Very, very interesting to see these social determinants of health now receiving their own specific guideline, not just kind of being lumped in with coma scale and stuff information. I think it's showing that these are becoming much more significant to our full medical picture and patient health as well. So this continues on. It says social determinants of health codes are primarily located in these Z code categories, and then it basically tells you all of the stuff that's in here, the Z55 through Z65, persons with potential health hazards related to socioeconomic and psychosocial circumstances. So these would be our social determinants of health codes, and that's what they're listing here. Things like the Z55, problems related to education and literacy, as well as Z60, problems related to social environment, etc., etc. Now, lastly, this is where we have our COVID-19 code. So our chapter 22 is our codes for special circumstances. And we have here U07.0 is our vaping related disorders. It says to see section 1C10E, vaping related disorders. So basically what that says is for patients presenting with conditions related to vaping, we assign U07.0, vaping related disorder, as the principal diagnosis. For lung injury due to vaping, we assign only U07.0, and we assign additional codes for other manifestations such as acute respiratory failure or pneumonitis. Associated respiratory signs and symptoms due to vaping, such as cough, shortness of breath, etc., are not coded separately when a definitive diagnosis has been established. However, it would be appropriate to code things that are totally different, such as GI symptoms if they're having diarrhea, abdominal pain, which is not related to that vaping disorder. You'll also see here that new code, the U09.9, which is our post-COVID-19 condition unspecified. And then it tells us to see our section 1C1G1M, which is the big section that we looked at earlier, where it talks about the sequela of those COVID-19 conditions and how we should not be using U09.9 if it is a manifestation of an active current COVID-19 infection. So that's it for the guideline changes for 2022. Again, I'll be putting together a full webinar on all of the ICD-10-CM 2022 changes, so be on the lookout for that on contempocoding.com. I hope this video helped you guys out. I will see you in the next video, and until then, just keep on coding on.